We're going to talk in these slides about the B cell defects, which make up a good part of the primary immunodeficiencies that tend to show up in children. However, we're going to talk about one of these that can present in adults as well. The congenital immunodeficiencies include the B cell defects, which are primarily disorders in producing antibodies, the cell-mediated immunodeficiencies, which are T cell defects, the combined immunodeficiencies, which include both B cell and T cell issues, phagocytic defects, and then asplenia, which is itself its own monster. All right, so we'll talk about B cell defects here. We're going to talk about 4 of them. The last one, transient hypogammaglobulinemia of infancy, tends to be non-consequential, and it's certainly not something that you're going to deal with after a year of life or so. So I'm not going to talk about that in detail here. You can look this up if you want. I don't expect the test to ask you about this. However, if you're taking pediatric certifying board exams, then you'll want to know about that one too. So as you can see, hematopoiesis is obviously very complicated, very complex. There's a lot of cell factors that are involved in maturing these cells to their cell of destiny. But they do all start from what's known as a pluripotent hematopoietic stem cell. Now, please don't memorize this. Certainly, there are some parts of this that are worth knowing for the test, but I'll point those out to you as we go on. So you don't need to know all of these. However, you will want to know what they do, certainly, what the destiny cells do, the mature cells, what they do. But you don't memorize any of these cell factors or anything. I wouldn't worry about that. All right, so we're talking about B cell defects here, and we want to know where the problem is at, because that's going to not only tell you what the disease is, but it's also going to give you a lot of information on how severe the disease is, what antibodies you are and aren't going to see. And so I figure it's probably useful to have some idea of how these B cells mature. So as mentioned, we start with this hematopoietic stem cell, which is sort of the father of all these cells, but as they mature, they become more specialized. Now, a lot of these intermediate cells are really useless, and we're going to see that is certainly the case when we have issues that arrest these cells at stages, intermediate stages in their development. They don't really do anything useful to us, and therefore, since they're not producing antibodies, since they're not phagocytizing pathogens, we're going to have immunodeficiencies if we have an arrest at some point in this process. So a couple things worth knowing. We're just going to be talking about B cells here. But as B cells differentiate, you're going from a lymphoid progenitor, which can go on to be either B or T cells, and from there you start out as an early pro-B cell. You have heavy chain rearrangement. Heavy chain rearrangement, very complex. Again, we're talking about things that happen at the DNA level, the pre-transcriptional level. So you can make this as complex as you want it, but as far as for medical licensing board examinations, I'm going to try to make this easy for you. So you have heavy chain rearrangement, great. Okay, so after heavy chain rearrangement, now you express antibodies on the outside of the cells, so you're starting to turn into a regular B cell. Some of those cells, since they don't express anything that the body finds to be useful, they're going to apoptose. Other ones will go on to light chain rearrangement. Some of those will apoptose. The ones that continue and go on and have their light chains rearranged and they don't apoptose, they'll now be considered immature B cells. So they'll express this B cell receptor. It's no longer a pre-B cell receptor. It is a mature B cell receptor, and so this is an immature B cell. Ultimately, you're going to have splicing of H-chain transcripts, and that's going to allow you to express both IgM, which is part of your B cell receptor, as well as IgD. So you have both IgM and IgD expressed on the B cell. And this now is a mature B cell, and it can go on to do various things, such as become a memory B cell, which is sort of a clone that allows you to have more of that particular clone of B cells available to do other things. They can also become an IgM secreting B cell, which just secretes more IgM. Remember, IgM is sort of that first antibody that will be expressed as a B cell matures. It can also be turned into a plasma cell, which those can secrete IgE, IgA, IgG, and IgD. So remember, you have 5 immunoglobulins: IgM, IgA, IgD, IgG, and IgE. Okay, so that's basically how B cells grow up. That's their childhood. Oh, and I will note that, B cells, they start out in the bone marrow. Ultimately, they come out into the circulation. They also go to the thymus, and it's in the thymus. Remember, that's where T cells are, where B cells and T cells can interact with each other, and that's useful for something else, which we'll talk about in a specific disease process that we're going to touch on here. Okay, so B cell maturation is coupled to immunoglobulin rearrangement. All right, now this is kind of what I alluded to earlier. You start out with the stem cell, you go on, you have that VDJ rearrangement, the heavy chain rearrangement, and then you become a pre-B cell, so you're no longer a pro-B cell, you're a pre-B cell. And pre-B cells just mean that they're displaying some kind of antibody on the cell surface, a cell surface antibody, and that's an IgM antibody. After you become a large pre-B cell, then you go on to have light chain rearrangement, and then you express that light chain on the pre-B receptor, and now it becomes a B cell receptor, BCR. And that's an IgM antibody. And then you also, when you go from immature to mature B cell, you express IgD in addition to IgM. So now you express 2 different types of antibodies, and it's at that point where you're now a mature B cell. Now there's this checkpoint here, and this checkpoint is an important part of this process because it is at this part of the process where there is a certain disease, and it's going to be one of them that we're going to talk about, called X-linked Agammaglobulinemia, or Bruton's Agammaglobulinemia, where if you have a defect in one of the signaling proteins in this cascade, you're going to have an arrest. And that's what we see in that particular disease, and it occurs at this point right here. So B-cell immunodeficiencies basically just mean it's an inability to produce adequate amounts of all or specific types of antibodies. So you should immediately, and you probably already have, but you should immediately associate the word B-cell with the word antibody, because B cells make antibodies. They do other things too. They have some phagocytizing capabilities. However, B cells produce antibodies. That's their primary responsibility for most of them. If you don't have adequate antibodies, or you don't have certain kinds of antibodies, then you are at risk for immunodeficiency. And that immunodeficiency is going to be for certain types of pathogens. So the immunodeficiencies that you get from T cell defects are going to be different. The types of infections you get are going to be different from the kinds of immunodeficiencies you get from phagocytosis issues, from what you get with antibody deficiencies. So what happens if you have an antibody deficiency? Well, first of all, you are going to be at risk for infections from pyogenic organisms. Why pyogenic organisms? Because with pyogenic organisms, they have sort of a mucus around them, and you need to be able to opsonize them. And opsonize is just a fancy word for covering them with antibodies so that the cell can, some cell can eat it. So your cells like to sprinkle their food with salt and pepper, except they use, instead of salt and pepper, they use antibodies. So they cover these bacteria with antibodies, or viruses with antibodies, then they can eat them. However, if you don't have those antibodies, then they're not going to digest that bacteria, and so that bacteria can then proliferate. And so one of the major category of bacteria that are going to affect you if you have an antibody deficiency is going to be those bacteria that are encapsulated, and that includes Strep pneumoniae, and that's obviously a big one because that affects people in general, but people with immunodeficiencies that are antibody deficient are going to have Strep pneumoniae complications all the time. So we're talking sinusitis, pneumonia, bronchitis, meningitis, and that leads us to the second one, Neisseria meningitidis, which you know is a common cause of bacterial meningitis. Haemophilus influenza, and then Pseudomonas is also an encapsulated bacteria. Now, there's some other pyogenic organisms that are not encapsulated, but they are also going to be problematic if you have antibody deficiencies, and that includes things such as staph. So staph pyogenes, for instance. And then some other problems that you can get are from diarrhea-causing bacteria. I'm not so sure about the mechanism here, but what we tend to see is Campylobacter, and then Giardia. Giardia is not a bacteria. I should probably put a semicolon there. Giardia is a flagellated protozoa, and this is a very common cause of diarrhea as well. So we see in these antibody immunodeficiencies, we see chronic diarrhea, and then they can also get mycoplasma infection. And we'll talk about more specific ones for each of the diseases too. So this is this great mnemonic that I wish I had known during medical school, but it's some nasty killers have some capsule protection, and this is so you remember the encapsulated bacteria, and you know from what I just told you that with antibody immunodeficiencies you're at risk for infection with encapsulated bacteria. So we talked about some of these: Strep pneumoniae, Neisseria meningitidis, Klebsiella pneumoniae, Haemophilus influenza, Cryptococcus neoformans. So Cryptococcus can cause meningitis, and then Pseudomonas. All right, so Vignette 1. We're going to talk about a specific patient here. This is a 12-month-old boy who's brought to your clinic due to poor feeding and irritability for the past 12 hours. Mom says that this is the 4th time in the past few months she has brought him in, and each time he's gotten antibiotics for an ear infection. So 4 times in the last few months for an ear infection. On physical exam, you indeed note a red bulging and immobile tympanic membrane on the right side. There is no lymphadenopathy. On his chart, you note that he has been seen in the ED and the clinic 8 times, diagnosed with otitis media 4 times, pneumonia twice, and diarrhea twice, once of which Campylobacter jejuni was isolated. So what do you think is the most likely diagnosis? Now, certainly you're not going to make a diagnosis just on this alone. There's obviously something going on that's not right with this child that's going to necessitate at least blood work. So what do you think's going on here? And probably got a little bit of a hint since I told you what we're going to talk about here. Okay, I'm going to give you a little hint here in case you didn't look closely at the summary of what we're going to talk about. Mom notes that she has one male cousin who died of pneumonia at age 20 and an uncle who died from fever at age 42. All right, so this is obviously otitis media, acute otitis media, and it is most likely secondary to X-linked Agammaglobulinemia. So we talked about, there are a bunch of antibody deficient immunodeficiencies. Why is this most likely X-linked Agammaglobulinemia? We'll talk about the details about this. But here's the thing. X-linked Agammaglobulinemia. What do you know from this already? Well, it's X-linked. So X-linked is going to present in boys. Secondly, with X-linked Agammaglobulinemia, it has a tendency to present very early. So as soon as mom's antibodies are cleared out of the baby, they're going to be antibody deficient. So, you have antibodies that cross the placenta, and those are protective. for a while until you start to clear those, and then no longer do you have antibodies. And if you have Bruton's Agammaglobulinemia, you are unable to make your own antibodies, and therefore, once mom's antibodies are gone, you no longer have antibodies, and you are going to be prime breeding ground for those encapsulated bacteria. And that's indeed what we have in this patient. So we have repeated sinopulmonary infections, ear infections, pneumonia, and then diarrhea. And once Campylobacter jejuni was isolated. Now, occasionally Campylobacter we see in food poisoning, and it probably came from food. But the fact that it was isolated, usually, I mean, what's the most common cause of bacteria, or common cause of diarrhea in children? It's viral diarrhea by far. And so, since this bacteria was isolated, this is worth noting. And so you could have easily just said it was Giardia that was isolated too, perhaps. But Campylobacter jejuni was isolated from the diarrhea, and that gives you another little bit of a hint here. But the biggest hint is that it's a 12-month-old boy, and he's got repeated sinopulmonary infections that just do not go away. He's given antibiotics, they go away, but he just keeps getting them. And normal children, yes, they get infections every so often, and they're around other kids, they're at daycare, they go to kindergarten, they get infections, ear infections, totally normal, but not this often. And so, whenever you have a child that's getting they're either getting frequent infections, or they're getting normal infections that every other child gets, but very severe, or if they're getting infections from unusual bacteria, you should suspect an immunodeficiency. So X-linked or Bruton's Agammaglobulinemia is a mutation of the BTK gene, which exists on the X chromosome, on the long arm of the X chromosome, and BTK just stands for Bruton's tyrosine kinase. And this results in an inability of the B cells to properly mature, and thereby leads to very low to absent B cells. So you go back here. All right, so like I told you, there's an arrest, and BTK functions right around here. It functions at various stages, but right around this this point in time where the progenitor B cells are going through heavy chain rearrangement, and that's right around the time when BTK is most active. And so if you don't have BTK, this is where the cycle is going to, this is where the process is going to arrest. And you can see it's long before you get to that mature B cell, and certainly long before you get to class changing, where you can start to make the other immunoglobulins A, G, and E. So not only can you not make IgM, and not only can you not make IgD, but certainly you also can't make IgE, IgA, and IgG, right? So you can't make any of them, M, A, D, G, or E. All right, we'll go back here now. So this means that all immunoglobulin types are going to be very low to undetectable. And you're also going to have very low to absent B cells in the circulation. So this is really going to help you make your diagnosis, because in pretty much nothing else are you going to have absent B cells. We have other B cell defects where you have deficient antibody, but in those, even in those, you have some B cells present, some antibody present. Here it's totally depleted, gone. You don't have any antibody present, and if you do, it's in just tiny, tiny sparse amounts. So and it's going to be all immunoglobulin types, and that's going to be important because there are some of these antibody-associated immunodeficiencies where you will have some, maybe even too much of a certain antibody, but deficient in another. Okay, but in this case, all immunoglobulin types will be very low to undetectable. Typically, this manifests at 2 to 9 months of age after the infant has cleared the maternal antibodies. Clearing the maternal antibodies usually happens in before 6 months old. It's usually pretty early, like 2, 3, 4 months. But it will take a while for infections to start. And the thing is that babies get infections, and you're not going to be thinking immunodeficiency the first time, even maybe the third time that a baby comes in with an ear infection or with pneumonia. because it happens, and you're not going to think immunodeficiency in every baby that's coming in for the first or second time with some kind of an infection. And so typically this doesn't get diagnosed until around the first birthday, maybe even later. If you're very astute, or you have a baby that's gotten infections a lot at a very young age, then perhaps it might be diagnosed younger. But remember, it takes time to develop that clinical history where you have a child with repeated infections. So a lot of times this manifests 2 to 9 months of age. You start to get those infections, but you're not going to have a baby that has infections right off the bat. You're not going to have a baby that has an infection at 1 month of age because they still have those maternal antibodies. So around infancy, 1 year of age, maybe a few months later is typically when this gets diagnosed. Presentation is repeated infection, especially with the pyogenic and encapsulated organisms, which we talked about, in infant boys. Remember, this is X-linked. Now, theoretically, it can happen in girls if you have a carrier mother and an infected father or affected father. Then yes, it can happen in girls, or I suppose it could happen in girls who have Turner syndrome. But otherwise, this is pretty much exclusively in boys. Pneumonia, bronchitis, conjunctivitis, sinusitis, encephalitis, chronic diarrhea, which can be bacterial or viral. Now, these children are also susceptible to enteroviruses, so like echovirus or Coxsackie virus. And echovirus can cause a really, really bad meningoencephalitis. So these children with X-linked Agammaglobulinemia, they're at risk for what's called enterovirus-associated meningoencephalitis. I spelled that wrong there, sorry. Anyway, enterovirus-associated meningoencephalitis, this is a big one you have to watch out for. And this can be deadly, and it commonly is a cause of death in these children or adults if they do die from this. So when you do physical exam, failure to thrive is something that's not infrequent to see, because if you have repeated infections, your body is working overtime to clear the infection, and because it's doing that, you're expending energy, and so you're not growing appropriately. And remember, there's a lot of growing that's going on in that first year of life. You're growing pretty quickly. And then this is another thing, and I kind of alluded to this in the vignette. Yeah, here we go. So you note that there is no lymphadenopathy. Now, if you have otitis media, in a lot of cases you will have lymphadenopathy. Not all of them. It's not always noticeable, and you're talking about babies. It can be kind of hard to palpate and everything. But if you were to look at the baby's tonsils, you wouldn't see any, because this is lymphoid tissue. And lymphoid tissue is full of B cells. And if you don't have B cells, you're not going to have hardly any lymphoid tissue. It's going to be very small or absent. And so you will not note lymphoid tissue. And certainly this child won't have lymphadenopathy because they don't have lymphoid tissue. So even when there is an infection, there won't be lymphadenopathy. So this is Bruton's tyrosine kinase, and this is, do not memorize this, I swear. I only put this on here so you can get an idea of what this thing is that I'm talking about. So this is a B cell receptor, and you have, so this is right in that pro to pre stage, right? Yeah, pro to pre stage, and B cell receptor gets activated, activates Bruton's tyrosine kinase, goes through all these things, and ultimately stimulates the B cell to do its stuff, to replicate itself, to continue cellular activity, to mature. BTK is found elsewhere. It's not always stimulated by B cell receptor. It can be stimulated by other things, but just know that this transmits signals. It's sort of this messenger, and it stimulates maturation. And so if you don't have BTK, then the B cells aren't going to be able to mature, and you're definitely not going to get to be a mature B cell where you're producing IgM and IgG, and then ultimately, or IgD, and then ultimately the rest of the immunoglobulins as well. Other manifestations you can see in XLA. So this sounds really, really, really counterintuitive. And I'm not exactly sure why. Maybe somebody could tell me the exact mechanism, because I was a biochemistry major in college. I like to know the exact mechanism. So we know that it happens, but I don't know why, and I would like to know, and I couldn't find it online. But what we know is that a lot of these B-cell immunodeficiencies, they're associated with autoimmune disorders. And so you will see that. So what are some of the things you'll see? Autoimmune disorders, particularly inflammatory bowel disease. And this is problematic because remember that these children are already at risk for infectious diarrhea. And then you add on to that they're now at risk for inflammatory bowel disease. They can have some serious problems with their GI system. They're also at risk for rheumatoid arthritis, autoimmune hemolytic anemia, autoimmune thrombocytopenia, and autoimmune neutropenia. So increased risk for autoimmune diseases. You will also see an increased incidence of the skin manifestations, atopic dermatitis, eczema. These are very common in the general population too, but even more common in these children. And then pyoderma gangrenosum is a little bit more specific, you'll see with XLA. Now, I'm not sure, and I couldn't find any literature that differentiated this out, but pyoderma gangrenosum is also can be a manifestation of inflammatory bowel disease. So I'm not sure if the pyoderma gangrenosum is just a manifestation of inflammatory bowel disease, and that's why it's associated with XLA, or if pyoderma gangrenosum can just happen on its own if it's independent from IBD. Not sure, but pyoderma gangrenosum is something that tends to show up in this disorder. Remember what pyoderma gangrenosum is? It's just those sort of ulcers that come out of nowhere. Usually there's some kind of blunt trauma. It could be inconsequential, but some sort of blunt trauma, and then boom, you develop this sort of ulcerating, nasty, pussy lesion on the skin. And then this syndrome called dermatomyositis meningoencephalitis syndrome. I wouldn't worry about that for the test, but I thought I'd put it there for completion's sake. So what do we do for diagnosis? All right, anytime you have a child or you think immunodeficiency, what's the first logical step? Obviously, going to be a CBC. You want to look at the white blood cells and see if there's anything going on with that. What you want to look for is to see, is this a case of neutropenia? Certainly congenital neutropenia is something that exists and should be considered. You also want to look at the lymphocytes, and indeed, the lymphocytes are going to be implicated in B-cell disorders. So you get a CBC, you want to get a smear because you want to look to see if there's any abnormalities. Another thing that can cause children to get infections frequently is leukemia. So we want to get a smear, and then a manual differential. So you will see a decreased absolute lymphocyte count. Well, that makes sense, doesn't it? Because you don't have B cells. And if you don't have B cells, of course, your lymphocyte count is going to be decreased. However, your neutrophil count should be normal. So your ANC will be normal. And this is going to help you differentiate this out from something that's called hyper IgM syndrome, where you tend to have a neutropenia. And that can also present very early on in life. If you get a SED rate, it's kind of variable, but it may be elevated, probably will be elevated, at least in this child that we talked about, and this indicates a chronic infection, some kind of chronic infectious process that's been going on. It could be either one big long infection or just multiple insults, but SED rate can be elevated. And then this is probably the most important test because it's going to help you the most. It's quantitative immunoglobulins, and what you're basically doing here is you're just testing levels of all the immunoglobulins. It's a little more complicated than that test-wise, but quantitative immunoglobulins, you're getting levels of your immunoglobulins. And what you expect to see are very low levels of all immunoglobulin types, and that is a very specific finding for X-linked Agammaglobulinemia, which is going to really be the only one where you're going to have reduced level of all the immunoglobulin types, including IgM. And remember, IgM is the very first antibody that you create. It's the antibody that's sort of being created during the maturation process of the B cell. So IgM will be low in addition to all the other immunoglobulins. Now, On the contrary, another thing we're going to talk about called common variable immunodeficiency, or CVID. You'll have IgG and IgA low, but IgM will be present. In some patients, it'll be low, but it won't be as low as XLA, and the presentation is quite different. So that'll kind of help you too. With IgA deficiency, as you can imagine, only IgA will be low. Okay, so now that we talked about quantitative immunoglobulins, I want to tell you something that will help you in the hospital, especially if you're on a rotation like infectious disease or something like that. If you are getting a quantitative immunoglobulin level, you need to compare it to age-appropriate levels. The reference range for the immunoglobulins, they vary based on age. So small babies will not make certain immunoglobulins in as much quantity as older children, as adults. And so you need to be aware of that anytime you're getting a quantitative immunoglobulin level, you have to compare it to age-appropriate levels. Now, that having been said, when you get labs, they're going to probably give you the age-appropriate level on there, and certainly on the test they will. But it's just something to know. You can't just go down a list of 5 numbers and say, oh, this is the normal IgG level, this is the normal IgA level. You can't do that. It's going to vary based on age. And so once you do this sort of initial battery and you're still thinking X-linked Agammaglobulinemia, so particularly if you have very low levels of all the immunoglobulin types, then you're going to do flow cytometry. And flow cytometry is a wonderful test that is very accurate. And what you're basically just doing is you're looking for these antibodies that exist on different cells. And you can do flow cytometry for all different kinds of things. But you're essentially just, I don't know exactly how flow cytometry works physically, but what you get to look for are these cell sort of factors that exist on the wall of the cell. So in B cells, you have CD19 and CD20. And so if you want to look for B cells, then you look for these antigens. And if you don't have these antigens present when you do flow cytometry, then you know that you don't have B cells. Your B cells are absent. And so with X-linked Agammaglobulinemia, since the B cells never mature, you will not have CD19 or CD20 present on the cells, and so that will be consistent with absent B cells. Now, in the case of CVID or IgA deficiency, B cells are present. There's immunoglobulin issues, but it's the B cells are there at least. So this one is the most severe. We're talking about it first. XLA is the most severe of the B cell immunodeficiencies, and that's just because this problem occurs so early on in the process. So there's going to be no B cells present, no antibody present, and that's going to help you with diagnosis. Okay. All right, management. So there is no curative therapy for XLA. What you do, and this has really helped with life expectancy, is IVIG. And what IVIG is it's basically immune globulin that's been compiled from tons of people, I think like 60,000 people, and it's put into this solution and it's administered IV, and you give, and it basically provides these, even though the person can't produce it themselves, it provides the immune globulins that help fight off some of the infections that they're susceptible to. So it's given every month, and this is the mainstay of therapy for XLA. Antibiotics should be given as appropriate for infections, of course. Annual pulmonary function tests. Why do we want to do that? Well, because these patients are at risk for pneumonia and bronchitis, and then with insults from that, over enough time, you start to get chronic lung damage. Atopic dermatitis and eczema can be managed as usual with topical corticosteroids. Nutritional supplementation will be useful. Remember that these patients are at risk for giardia, diarrhea, which reduces the fat absorption, and also because since they have infections so frequently, they're expending energy that way. So these children have a tendency to be thinner or at risk for malnutrition. So we want to make sure that we're supplementing their diet as needed. And then if they are having diarrhea bouts, we want to make sure that we're hydrating them, and that's just common sense. And infectious disease referral would probably be useful in this case, since they're very good at dealing with infections and the complications of infections, and they tend to have a pretty good working knowledge of XLA. Prognosis. Prognosis is pretty good, actually, if you're receiving IVIG. Now, when I say good, I mean good compared to what it used to be. So now that we have a better idea of what this is and we get on top of it earlier, prognosis is better than before. Still, the average life expectancy is only about 40 to 50 years old, but considering that in the past these kids tend to die of this, when they were still in early childhood, it's pretty good compared to what it was. There are comorbidities with inflammatory bowel disease. Remember, that's going to just by itself increase your risk of colon cancer. CNS complications can come about from repeated enteroviral infection, which, remember, causes meningoencephalitis, so you can get seizures. The cause of death is usually either a serious enteroviral infection or chronic pulmonary disease, which ultimately causes cor pulmonale and congestive heart failure. Okay, so here we have a second vignette. Now we have a 44-year-old woman. Whoa, I thought we were talking about pediatrics. Well, we're talking about adults now. I can't help myself. 44-year-old woman presents to the clinic complaining of bleeding gums and epistaxis for the last 3 days. She denies any trauma and is not on any antiplatelet medications. She denies hematuria, GI bleeding, or any other symptoms. Family history is non-contributory. You note on her chart that she has a rather extensive past medical history. In 1993, so we're saying that's 22 years ago, she was diagnosed with ITP, which did not respond to steroids and required splenectomy. In 1998, she was diagnosed with cold agglutinin hemolytic anemia. In 2010, she was diagnosed with rheumatoid arthritis. You also note multiple hospitalizations for pneumonia and 2 for meningitis. Throughout her life, she has had frequent ear and sinus infections, which remitted with antibiotic therapy. Current medications include adalimumab and ibuprofen. On physical examination, she is afebrile, vitally stable, and there are petechiae on both forearms and apparent gingival bleeding. Okay. So this patient has, what does she have acutely? And this has nothing to do with immunology or even pediatrics. This is just a general medicine question. What does she have right now? I'll give you a hint. It's in the vignette. She has ITP. And particularly, she has ITP in association with common variable immunodeficiency. So the rule of thumb with common variable immunodeficiency, as you're going to see, is anytime you have a patient with apparent immunodeficiency, particularly immunodeficiency to these encapsulated organisms, which is going to include sinopulmonary infections, meningitis, ear infections, and that in conjunction with these autoimmune diseases like RA, like ulcerative colitis, inflammatory bowel diseases, Crohn's disease, ITP, hemolytic anemia. You combine those two, you more than likely have a patient with CVID, common variable immunodeficiency. Now, what also helps us here is the fact that this is an adult, and CVID has a tendency to manifest in grown-ups. As a matter of fact, 2/3 of cases manifest or are diagnosed, at least, in patients older than 21. So that's going to help you. Now, in general, CVID gives you the same kinds of infections as you get with XLA. It's the encapsulated organisms, it's pyogenic organisms, It's Giardia, Campylobacter, Echovirus. The one exception is that they don't have a risk for that meningoencephalitis. Now, she had meningitis, but that was probably Neisseria, and you could go back and look at that, maybe. So this is ITP, and ITP is pretty common with CVID. So this is the most commonly diagnosed immunodeficiency, making it difficult to pin down as far as mechanism, how it works, is that it's very heterogeneous in presentation. We haven't been able to isolate a single gene that causes CVID. There are some things it has in common with XLA. First of all, it's got a common infection profile. Encapsulated organisms, pyogenic organisms, causes diarrhea. And then also that there are autoimmune manifestations that occur. So autoimmune hemolytic anemia, ITP, psoriasis, eczema, IBD, rheumatoid arthritis, pyoderma gangrenosum, and so forth. So after that, it's pretty much not similar to XLA. So unlike XLA, this has an autosomal recessive inheritance pattern. Now, it's not always autosomal recessive, but it's not X-linked. It's not, whereas with X-linked Agammaglobulinemia, Bruton's, it's always X-linked, obviously by its name. With this, it tends to have an autosomal recessive inheritance pattern. It can be sporadic. It can be autosomal dominant with various expressions. So it's not X-linked. All right, so women can get this too. And that also kind of helped us in our vignette that this was a female patient. Another thing, big. More than 2/3 of patients will be diagnosed older than age 21. Children with XLA will not go past their second birthday without you knowing something is up, that they have some kind of immunodeficiency going on. Thirdly, immunoglobulin levels will be low, but they will be higher than in XLA. Lymphoid tissue will be visible, unlike in XLA, where the lymphoid tissue is either atrophic or absent. As a matter of fact, it may be enlarged. So you can have splenomegaly, hepatomegaly, or lymphadenopathy in CVID, whereas in XLA you would never have that. There's also something called a CVID enteropathy, which is very similar in appearance to celiac disease, where you get really bad stomach aches and diarrhea, and it can be bad enough to where they start to lose weight. But if you start them on a gluten-free diet, they're not going to get better. Now, here's one of the problems. And we're going to see this with the selective IgA deficiency. Patients who have some of these immunodeficiencies are at risk for elevated risk for celiac disease, up to 4 times as high a risk compared to the general population. However, because a lot of these patients don't have IgA, and that goes for CVID, that goes for IgA deficiency, that goes for hyper IgM syndrome, and I guess X-linked Agammaglobulinemia too. Because these patients don't have IgA, you can't test them for celiac disease in the traditional way we test them. What's the traditional way we test a patient for celiac disease? We get anti-TTG antibodies. That's an IgA antibody, and even if they do have celiac disease, they're not going to have that antibody present. So the only way you're going to be able to diagnose celiac disease in these patients is just with getting an endoscopy and getting a biopsy. However, these patients will have the CVID enteropathy in many cases, looks just like celiac disease, doesn't respond to a gluten-free diet. Next, they're not susceptible to the enteroviruses as far as that meningoencephalitis issue goes. And then this also manifests later in life, and then there's an increase, and this is important too because this is a common cause of death in these patients, increased incidence of hematologic malignancies, especially the B-cell lymphomas. So for diagnosis, it's pretty similar to, as far as your diagnostics, it's pretty similar to XLA. So you'll start out with the CBC and smear and manual differential. It's going to be a decreased absolute lymphocyte count, and C should be normal. SED rate may be elevated, which just indicates that there's a chronic infection going on. Quantitative immunoglobulins will be pretty similar to what you see in XLA, except the immunoglobulins will be not not as depressed. And as a matter of fact, the IgM may actually be normal. So it really just depends at what point this, because it's so heterogeneous, you can see that this disorder can occur at different parts of the maturation sequence. And so you may or may not have normal IgM. Remember that if you're going to have any of these immunoglobulins that's normal, it's going to be the earliest one, IgM. So IgM may be normal. And so if you have a normal IgM but everything else is low, then you have CVID. Now, if IgM is elevated and everything else is low, you don't have CVID. You have hyper IgM syndrome. But in this case, IgM should be normal, maybe low, but everything else is going to be low. But they will be present, unlike in XLA where they're going to be severely low if not absent. So in the case of XLA, all immunoglobulins are invariably low and typically much more so. In the case of IgA deficiency, only IgA will be low. Everything else should be normal. And in the case of hyper IgM syndrome, IgM will be high and everything else will be low. With a positive screen, so once you have this picture, you'll get a flow cytometry looking for CD19 and CD20. B cells will be present, and that distinguishes it from XLA. I only really put this here, though, for academic purposes, because if you have a 44-year-old woman, you're not thinking XLA. Management. So we give IVIG just like an XLA every 3 to 4 weeks. We give antibiotics just like an XLA for infections. Annual pulmonary function tests. Again, same reason. These patients get bronchitis and pneumonia. You get it enough, you start to get chronic lung damage. Some sources recommend more than annual. I guess it probably annual would be a minimum, and if they have repeated infections or if they have superimposed COPD or something like that, you might want to get it more often, but annual at least. Routine monitoring for malignancy. This is a big one because remember, these patients are at risk for lymphoma. So anytime there is an enlarging or enlarged lymph node that doesn't go away and it's painless, you need to get a biopsy on it. Atopic dermatitis and eczema can be managed with topical steroids, nutritional supplementation, vigorous hydration for diarrhea, and infectious disease referral. So basically the same management as we do for XLA. The only thing you're doing in addition is this routine monitoring for malignancy. Prognosis is good if they receive regular IVIG. The problems are the comorbidities with IBD, and cross this out here. So no CNS complications. Cause of death is typically lymphoma is the most common, besides natural causes, I suppose. Severe autoimmune disease can result in organ damage, which will shorten the lifespan too. So just remember, lymphoma is a big thing to look out for in these patients. All right, Vignette 3, we have a 21-year-old man presenting to the clinic complaining of mild diarrhea for the past 6 months. He denies blood or mucus in the stools. He has no other significant past medical history and is not on any medications. He denies alcohol, tobacco, and recreational drug use. He's afebrile and vitally stable. There's no lymphadenopathy. On review of his charts, you note that he has 1 previous hospitalization for pneumonia and several diagnoses of acute otitis media since childhood. He's lost 10 pounds since his last visit 9 months ago. His BMI is 20.8. On further questioning, he tells you that he has a cousin who also has problems with ear infections and diarrhea, but he tells you that her diarrhea went away when she stopped eating bread, and he now wonders if he should do the same. On labs, CBC, BMP, and stool studies are unremarkable. All right, so based on that, what does this guy have? So he is presenting with something, and it has nothing to do with immunodeficiency. So this guy is giving you a pretty classic case of celiac disease. Celiac disease, the way it tends to present, is chronic diarrhea with no blood or mucus, no fever, no signs of any kind of infection, nothing that makes you think inflammatory bowel disease, and weight loss, indicating that there's likely some fat going on too, and that fat loss is just due to chronic inflammation of the bowel. So we think that he's got celiac disease, but then in addition to this, We know that he has got these repeated episodes of acute otitis media, and there's also a cousin who happens to have the same thing, which makes you wonder if there's a genetic component. And indeed, there is. So this is celiac disease in association with selective IgA deficiency. Now, that's a presumptive diagnosis. You're going to need to do more testing to confirm that. You certainly cannot make this diagnosis clinically, but the reason that we think this is selective IgA deficiency is because IgA deficiency, if it presents at all, it's going to be, the infection history is going to be pretty mild. So studies have shown that up to 90% of patients who have selective IgA deficiency actually don't even know that they have it. So you can imagine it's pretty silent, but this frequent diagnoses of acute otitis media is something that appears to be something. All right, so selective IgA deficiency is a inherited inability to secrete IgA. We don't exactly know what the gene is, but we do know that there is a tendency for it to happen in families. In greater detail, it's a failure of terminal differentiation of B cells that secrete IgA. And immunoglobulin A, a few things about it is that it plays a critical role in mucosal immunity. So there are a lot of parts of your body, especially the mucosa, that are exposed to foreign things. So think the respiratory epithelium, you're breathing in bacteria. Your respiratory epithelium needs a way to fight that bacteria before it gets in through the cells and into the bloodstream, for instance, or before it colonizes. The GI tract, you eat things with bacteria on it. You swallow things with bacteria on it. Your GI tract has tons of bacteria within it. You need to be able to keep that bacteria from colonizing or doing something it shouldn't do. And the GU tract as well. So that's sort of your mucosal immunity. And immunoglobulin A is the immunoglobulin of your mucosa. It's secreted by various cells in these mucosal linings. As a matter of fact, and this was news to me when I was doing my research putting this together, you secrete 4 to 6 pounds of immunoglobulin A every day. Now, a lot of that's reabsorbed and everything, but that's a lot. You make a lot of this. Some other things about it, most of these patients will have IgA B cells. The problem is, and so that's surface IgA, the problem is they cannot secrete that IgA into areas where it needs to act. There's 2 different forms of IgA. There's a monomeric IgA, which is most of it, and then there's a secretory IgA, otherwise known as SIG-A. And this is an IgA dimer that contains a component, sort of this proteinaceous component called a secretory component, and it protects it from proteolytic enzymes, so it can be out in like the GI tract and not get broken down. Secretory IgA, what it does is it neutralizes viruses, it binds toxins, it agglutinates or opsonizes bacteria. It also prevents bacteria from entering cells. Now, the genetics to this is, we know that there's a preponderance in families. We also know that there's some kind of relationship with CVID. We also know that it's very possible for a patient who's diagnosed with selective IgA deficiency to then develop CVID. So there's probably some kind of genetic relationship going on here. The frequency in the general population is difficult to characterize because it varies so much among ethnicities. So in the United States, the group that's most likely to have selective IgA deficiency would be African Americans, about 1 in 6,000. Now, if you compare that to the population in the UK, it's 1 in 120,000 at large. If you compare it to the population in Sweden, and Sweden is a relatively homogeneous northern European country, it's 1 in 20,000. But if you go to the Arabian Peninsula, which is a pretty homogeneous Semitic population, the frequency is 1 in 142. So there's a very wide range of frequencies depending on the ethnic group. Manifestations. So most patients with selective IgA deficiency are asymptomatic. Clinical manifestations would include recurrent sinopulmonary infections with the pyogenic encapsulated organisms that we see so frequently in the antibody immunodeficiencies, staph infections, and then diarrhea due to viruses, bacteria, and giardia. There's also an increased incidence of autoimmune disorders here, atopy, celiac disease, and food allergies. Okay, this is big. Up until now, we've talked about two things. We talked about X-linked Agammaglobulinemia. We talked about common variable immunodeficiency. For both of those, the treatment of choice was IVIG. So why not do it in IgA deficiency? We don't. Okay? 10 to 44% of patients with selective IgA deficiency will have antibodies to IgA. Well, I thought we didn't have IgA in IVIG. Well, there is some, and all it takes is a little tiny bit, just like it takes a little tiny bit of bee venom, and you can die from that and go anaphylactic and die. So, because 10 to 44% of patients have antibodies to IgA, we never give them IVIG. So, never, ever, 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 ever do we give IVIG to patients with selective IgA deficiency. And then, apart from that, these patients are just not at as high a risk for infection or as severe infection as the XLA and CVID. So, we do not give these patients IVIG. So for diagnosis, if it's suspected, quantitative immunoglobulins can be obtained. There will always be normal IgG and IgM levels, just by definition, because this is selective IgA deficiency, just IgA. Only IgA levels will be low. And then, like I said, remember to use age-appropriate ranges for immunoglobulin references. Management. There's no specific treatment. Typically, we're not super concerned about preventing infections here because they just tend to not be very bad. You should identify any comorbid conditions, so celiac disease, inflammatory bowel disease, etc. And then you can consult ENT. That tends to be where the comorbidities that are correctable happen. So sinus and ear issues, you can do a tympanostomy. You can get functional endoscopic sinus surgery for recurrent sinusitis. So you're basically just managing the complications, but they tend to not be too bad. Okay, our last vignette. We have a 3-year-old boy presently in your care diagnosed with pneumonia. He's been on IV ampicillin and gentamicin for 4 days, but has shown no signs of improvement. Though he had been well for some time prior to this illness, he has struggled with repeated bouts of AOM and sinusitis, which have necessitated multiple trips to the ED. Those cases resolved with standard antibiotic regimens. He is afebrile and vitally stable on 4 liters per minute humidified oxygen via nasal cannula. Physical exam is remarkable for mild rhonchi, which are diffuse. You also know oral ulcers, which his mom says he gets often. Serial CBCs have shown neutropenia and a decreased ANC, which has prompted you to consult pediatric oncology. They have not yet responded. However, as you check his labs again, you note that the sputum culture has finally came back and has tested positive for pneumocystis jirovecii. You treat him with trimethoprim sulfonatoxazole, as you should, and he begins to show signs of recovery. You now wonder what to do next. You're befuddled now. So let's just say that you decided to get all, got the works done on the culture and you tested for pneumocystis jirovecii, even though we had no idea that that was going to happen. This is kind of giving you a hypothetical here. Okay, so the diagnosis here is pneumocystis jirovecii pneumonia as well as neutropenia, and this is associated with hyper-IgM syndrome. Hyper-IgM syndrome is unique among these 4 we've talked about, in that hyper-IgM syndrome implicates the T cells as well. It's primarily I included it with these B cell defects, even though it's not necessarily, it can be, but it's not necessarily a defect of the B cell. It can also be a defect of the T cell. However, we're talking about more specifically here, it's not just B cell defects, we're talking about antibody associated immunodeficiencies. And this is a disorder of antibody production. It always is. So what we see here is a patient with pneumocystis jirovecii, not something that you see outside of severely immunocompromised AIDS patients. And we also see that this is a patient who has repeated bouts of AOM and sinusitis. So repeated bouts of AOM and sinusitis equals susceptibility to encapsulated organisms, which you should always associate with antibody immunodeficiencies. So we see that. We also see two other things. We see oral ulcers, and we see neutropenia with decreased absolute neutrophil count. Neutropenia is highly associated with IgM syndrome, or hyper-IgM syndrome. Of course, it's not very specific, but it is associated with hyper-IgM syndrome. And the reason is because T cells are responsible to help stimulate a leukemoid reaction. And so if there's in this case there is something wrong with signaling with the T cells, and more specifically, it's the CD4 ligand interaction that helps stimulate the leukemoid reaction, and that's really the problem in this case. So let's look at this in greater detail. Hyper-IgM syndrome is a congenital syndrome typically due to deficiency of the CD40 ligand, which is expressed on B cells. Most commonly, hyper-IgM syndrome is X-linked, so you'll tend to see this in boys. However, deficiencies of CD40 will be, I believe, autosomal recessive. So you can see things that look just like this in girls, but it tends to happen in boys because the most common cause is X-linked. CD40 ligand CD40 interaction is, among other things, necessary to induce class switching. Now, if you go way back to the very beginning, I'll switch back there just a picture here. I don't know if I put another one in, so I want to show you here. All right. Oh, please tell me I've got one. Okay, here we go. So if you go way back to B cell differentiation, you have this mature B cell here, right? And you want to make other things than just IgM and IgD. You want to make other antibodies. And in order to do that, you have to do something called class switching. Class switching allows you to create different types of antibodies other than just IgM and IgD. And so class switching is reliant on a signal that comes from two different things coming together, interacting, and that is CD40 and CD40 ligand. And once that interacts, then you get class switching, and you can create other antibodies. And in the case of, okay, all the way back here, in the case of hyper-IgM syndrome, that interaction cannot happen because either CD40 ligand is mutated or disrupted, or CD40 is mutated or disrupted, and so you can't get that signaling. There's other hyper-IgM syndromes in which a downstream protein in that signaling cascade is disrupted. That can happen too, but we're just going to consider the simple case here. So you don't get IgA, IgG, or that should be IgE, not IgG. But you have a ton of IgM because you continue making B cells and you're stimulating B cells and you're making tons of IgM, but everything else is going to be low. IgA, IgG, and IgE are going to be low. So high levels of IgM, but very low levels of the other immunoglobulins. These patients will have a susceptibility, and this is going to separate it from the other three we talked about, both to pathogens that are cleared by the humoral-mediated mechanisms, but also those that are cleared by the cell-mediated mechanisms, which would be opportunistic infections. So we would never expect to see pneumocystis jirovecii pneumonia in a patient with X-linked Agammaglobulinemia. As bad as that disease is, they don't get pneumocystis jirovecii pneumonia. But hyper-IgM patients do because there is an issue that is involving the T cell as well. The T cell is coming into play when you're talking about CD40 ligand interaction. The presentation is going to be what you tend to see in the antibody problems. So chronic infection with pyogenic encapsulated organisms leading to pneumonia, bronchitis, sinusitis, and encephalitis. They are also at risk for chronic diarrheal infections, including viral, bacterial, and cryptococcal. It's not uncommon for these children to present with pneumocystis pneumonia. So you should highlight this, write this down, because pneumocystis pneumonia in a baby is going to point you towards hyper-IgM syndrome. Like XLA, these patients are at risk for that enterovirus-associated meningoencephalitis. So that's just going to be the XLA and hyper-IgM syndrome. You don't see that in CVID. You don't see that in selective IgA deficiency. And as with any chronic diarrhea, you can have failure to thrive. So if this presents in a child that's 12 months or 2 years old or 2.5, you can see failure to thrive because they have chronic infection. CBC will show neutropenia. Again, this has to do with that T cell coming into play here. So you will have neutropenia and a decreased absolute neutrophil count. You will not see that in XLA. And XLA is going to be the one I want to compare this to because they tend to present in roughly the same age period. Unlike XLA, this is much rarer. This is only about 1 in a million in the US. So for diagnosis, start out with the CBC, smear, and manual differential. You're going to have neutropenia. So neutropenia is something that you will also see in another patient population that tends to get infection, and that is leukemia patients. Now, leukemia can be neutropenia. It can be high neutrophils or high leukocytes, at least. But what you will also, what you will have in hyper-IgM syndrome that you will also have in leukemia is that decreased absolute neutrophil count. That's really the thing you want to look for in either of these. So a decreased ANC. And that was probably the reason that this doctor decided that he wanted to consult pediatric oncology. And just knowing that there was a decreased ANC and a kid with infections, repeated infections, yeah, that's probably a good idea. Because leukemia is certainly more common than hyper-IgM syndrome. SED rate will be elevated, indicating chronic infection, and then if you get quantitative immunoglobulins, you will see that there are high levels of IgM, but the other immunoglobulins are low, and that is practically diagnostic for hyper-IgM syndrome. You have an immunodeficiency, then you get immunoglobulins, and you see that, well, IgM is high. Now, why do you have an immunodeficiency if one of these are high? Hyper-IgM syndrome is really going to be the answer to that, especially if it's high IgM. It sort of fits with the name, too. Plus, if you have a clinical history of pneumocystis jirovecii pneumonia, that nails down the diagnosis even more. So with a positive screen, you can do flow cytometry. That will demonstrate the presence of IgM and IgD cells, but no IgG or IgA cells. Wait a minute here. Why do we have present IgD cells? I thought this was hyper-IgM syndrome. Why do we have IgD cells present here? Remember, if you go back, I'm not going to go all the way back there, but if you go back to B-cell maturation, at the very last step before you become the mature B-cell, which you can do that, you can become a mature B-cell, you have IgD production too. So IgM will be will show up on the immature B cell. You'll have IgM only, and then once you get alternate splicing of the H-chain transcripts, you'll be able to produce IgD. It's just surface IgD, but you will have positive surface IgD, and that's what you're looking for with flow cytometry. You're looking at what's on the surface. So you have positive IgM and IgD cells. Basically, what that's telling you is you have mature B cells, but you don't have IgG or IgA surface antibodies, and that can only happen once you switch, once you do class switching. And then you should always refer these patients for genetic testing. So what do we do for them? We give them IVIG, just like we do in XLA or in CVID. We give them filgrastim. Filgrastim, also known as Neupogen. It's a GM cell line stimulating factor, and this is done to help with the neutropenia. Now, this is not going to elevate. It's not going to elevate your immune globulin levels. It doesn't work on lymphocytes. This only works on the myeloid line with the neutrophils. So that helps with fighting infection. but it's not going to give them the antibody that they're missing. You only get that with IVIG. So remember, they're missing antibody and they have a neutropenia. So to give them the missing antibody, we give them IVIG. To help with the neutropenia, we give them filgrastim. We also, as soon as they're diagnosed, we put them on pneumocystis jirovecii prophylaxis, just like we would do for AIDS patients. And that is done with trimethoprim sulfamethoxazole. Antibiotics are given for infections as necessary, and because, just like all these other patients we've been talking about, they're at risk for sinopulmonary infections, we do pulmonary function tests annually. This can be cured with bone marrow transplantation, which you can consider in young, relatively healthy patients, especially if they have a sibling. Test their sibling for HLA match. If they're a match, you can do bone marrow transplant. The prognosis is guarded. It's pretty much just similar prognosis to XLA. If you start IVIG early and they do it frequently every month as they should, and they're religious about it, they tend to have a pretty good prognosis. All right, so that is it for the B-cell issues. If you have any questions, go ahead and let me know. Otherwise, I will see you in the next section.